Welcome back to Out of Network. I'm Dr. Ryon Parker here with Dr. Rishi Seth. Today we're talking about something that started as a convenience during the pandemic, but has now completely changed how people get their care: telemedicine. For a lot of people, telehealth is just hopping on a video call with your doctor. But behind the scenes, there's a whole other world, especially in small towns and rural hospitals where there may be no doctor in the building at all.
I spent years working as a telehealth hospitalist, taking calls from 100 miles away, running codes over a screen, helping nurses manage emergencies, and supporting hospitals that wouldn't survive without this kind of access. So today, we're breaking down how telemedicine actually works, where it helps and where it doesn't, and why it's becoming one of the most important tools in modern healthcare. So with that, let's get into it.
So, Dr. Seth, what kind of started out as convenience during a pandemic, telehealth has, I feel, really changed access to your doctor. I know as a hospitalist, I'd love to hear a little bit more about your experience using telehealth in a hospital setting. I would love to share what I currently do in the concierge practice and make sure our listeners understand, the value of telehealth medicine and what that looks like. Can you share your story?
So when I moved to Tampa, I went from like a very busy hospitalist life to a not so busy hospitalist life.
Mm-hmm.
And then we decided to have our clinic. And one of the things I was trying to find was I'd heard there was work for hospitalists and telehealth, but I couldn't really find it. And really funny, I got a call one day to give a letter of reference for a physician who was signing up with a telehealth company. And so then I was like, by the way, do you have an extra job? So I picked up the job. So the job that they had was with a company based out of Minnesota. And I was not medically licensed. I was telehealth licensed, but I wasn't full licensed there. Mm-hmm. And then I was licensed in the state of North Dakota. So the company that I decided to work with, they are licensed in North Dakota, Minnesota, Iowa. So I had to get medical licenses there. And then I had to get credentialed in all the hospitals they work with. So it was about 16 hospitals. Actually, it was, in the 20s.
Okay.
And these hospitals are rural access hospitals in critical access. So they don't have specialties. Most times they may not even have a doctor on site.
Wow.
They may have a nurse practitioner, a physician's assistant who is possibly running some sort of care. Or if they do have a physician, that physician is also like the primary care, the inpatient hospitalist. They're running the whole show. Mm-hmm. And it's literally impossible for them to be there all the time. So the idea from that organization was they would provide care for the nights. Okay. And so patients come into the ER 24 hours a day. This would help out the hospital by providing hospitalist care, which is inpatient medicine to the general floor.
Okay.
That model has been started probably 2021. Prior to that, the real focus of telemedicine was they were trying to do outpatient stuff. And it seems like that wasn't working as well because patients, when they want to talk to their doctor, they want to talk to their doctor.
Right.
They want to see the doctor.
Mm-hmm.
They are willing to make a travel.
Mm-hmm.
During COVID times, it was different. Right. But when COVID restrictions came up, people came in droves. Mm-hmm. The difference between the inpatient and the outpatient is the mechanism of how the telehealth is done. So let's say I'm on screen, I get wheeled into a room.
And so there's actually, walk me through that. There's actually technology, mm-hmm. telehealth technology outside of just picking up a phone.
Right.
Okay.
Right. So this is probably like a 16 by, I don't know, like it's like a mini TV, mm-hmm. right? And it's wheeled in on wheels, mm-hmm. and it's got a stethoscope on it, and it's got a volume, and it's got a zoom. Okay, so it comes in, and I can like zoom in everywhere. I can zoom in really clearly.
So if I'm a patient in my small town, Nebraska, and I go into the ER, there's nurses, a PA, but they want an MD.
Yeah.
You could be in Tampa, Florida.
Yeah.
Provided you have a license in Nebraska.
Right.
The hospital has this technology, and I can interact with you when I'm in the ER.
They've been doing that for a while. So like in early 2010s, neurologists were providing stroke care for emergency rooms, patients who would come in for stroke protocols. They have weakness, they have diagnosis of the stroke. They don't have a neurologist in-house. Neurologists are hard to come by.
Sure.
So they have a neurologist at a central location. Then that thing gets wheeled in. The stroke neurologist does his exam, his or her exam.
Is there a nurse that's helping guide?
That's true. So it's really interesting because in 2009, I was involved in Miami. There's a hospital called North Shore. I was there when they first identified their first stroke like telehealth program.
Wow.
And so I saw it being done. And that was like space age kind of technology at that time, because Wi-Fi wasn't as strong before, but I saw it. It was really cool. They did a physical exam. The neurologist talked to the nurses, talked to the patient. They ordered the tests. The tests would come up on the neurologist's feed, and then he goes, okay, this is a stroke. This is what we're going to do. Now it's so readily available throughout the country that's kind of how it really started with these kind of specialty services. Then eventually, there was a pause in the specialty services. They decided to try outpatient stuff. That didn't go as successfully, although it's very successful in psychiatry. Because, imagine psychiatrists are able to do extensive amount of evaluation.
Sure.
In a telehealth evaluation. But where it's really seeming to become more beneficial is these rural access hospitals. And I love the idea of this now, because these hospitals are, if you think about it, like think about your small town where you're from. That hospital is kind of the lifeblood. If that hospital goes away, jobs go away for that community, and not only that, like a lot of healthcare goes away for that community. So these patients have to travel far. Now your doctor is on the floor 24 hours a day.
You can put in orders, write your notes. If the nurse needs something, I'm sure you're easily accessible if you're the telehealth doc on call, right?
Yep.
What if there are situations such as a code?
That's the big part. That's actually the part where it's really beneficial. So I've run, I don't know, probably hundreds of codes and hundreds of rapid responses in my life, maybe even more than that. So you need people who have experience.
Right.
So now the key about these critical access hospitals are, a lot of times they were taking care of patients who were sick. A lot of times they were taking care of patients who were too sick. And so some of the nuance of hospital medicine is knowing when to transfer, right?
Right.
And so like I would see a patient, I had an example, like this one time this patient got admitted onto the floor. I was a telehealth that day, and he just started complaining of chest pain. And it wasn't that big of a deal. And like the nurse is like, can you have a look? He looks kind of weird. The guy's telling me it's a 3 out of 10 chest pain, but he looks gray. Right? And now it's a computer screen. It's not the same.
Right.
You really need to understand like this, like the different levels of clinical identification. So I'm like, something looks weird on this. So we get an EKG. It's a full-blown STEMI.
Wow.
Which is ST elevation MI.
Heart attack.
Yeah. So I'm like, how does the guy have a STEMI and have a 3 out of 10 chest pain? Barely any pain. None of this makes sense. We call the cardiologist. The cardiologist is like, send him on right away. We get him on a helicopter. He gets sent
heparin drip going, pain.
Heparin drip, everything, aspirin, everything within seconds. This patient gets sent out to Minneapolis at a higher level center. He gets he ends up being found to have a critical left main stenosis. He gets a stent put in, and then he ends up seeing the cardiovascular team, and he's prepped for bypass. That patient if he did not have that critical access care, who knows what could have happened to him, right? So I actually think that telehealth in critical access hospitals, it's going to fundamentally change those communities.
Do you feel confident, and are those hospitalists confident in this technology? Do they? I mean, we're so used to being at the bedside, and we're so used to being told you need to examine the patient and touch the patient.
Yeah.
Do you feel confident that you can provide the care necessary and needed for a patient when you are thousands of miles away?
Yeah. What I would say is you need a lot of experience before you do telehealth. For the institution I work with, and I'm now their medical director. We won't hire anybody less than 5 years of experience, and it is not because that it is, like this is complex medicine. It's not complex medicine. And a lot of times it's simple medicine, but you need to know what to elevate. You need to know what to react to, and that's where experience comes in.
Sure. So for those hospital administrators that are listening to this and maybe struggling with staffing, and I know in my small town, at least at the time, limited doctors who were working daily.
Yeah.
And I can only imagine the call schedule at night. I mean, that's exhausting, high burnout rate. So this could be a good solution for these small town hospitals. That way it'll give a reprieve to those doctors, but at night their patients are still being covered.
Not only are they being admitted, they're being managed, right? That's huge.
Right.
A lot of times the providers in these small towns, I'm not going to say that they didn't have the experience, the knowledge, but they may not have had the experience of inpatient hospital medicine. Like taking care of a patient with congestive heart failure is very different from managing their outpatient heart failure management, right?
Sure.
So like it's just a little bit different. If you've done it 100 times, it's much easier to manage it. So as a telehealth hospitalist, I've done this 1,000 times, probably way more than that. So managing this stuff is easy. And so then you also know like the risks and the complications that are associated with it. So this way, we have so many docs who call us and they're like, I just need some advice. There's this patient in my clinic comes to me with this problem. I really don't know what to do, right? Now, not only are we admitting and managing the patient, we're giving guidance to that doc. And the benefit of that is he is not needing to send to a higher level of care for a specialist when they just need some simple management issues that they just need to run by. 99% of the time, the doc is 100% right. He or she just needs to run it by.
Reassurance.
Yeah. And that's super important too.
So why aren't more smaller hospitals in rural settings looking for this? Is it just a matter of they don't know?
Yeah.
Is it costly? I mean, you'd think they'd be jumping at this. I mean, I get job advertisements in my email all the time. Just recently, there's a hospital in Pawnee, Nebraska, Seward, Nebraska, who are having difficulty finding nocturnists to oversee their ER and their inpatient suites. Yeah. So do they not know about this technology? Is it too expensive for these smaller hospitals?
Well, it depends. Sometimes the hospitals have smaller budgets, right? So I actually think that it's perfect for them,
right?
Because to hire a physician might be so expensive that they're not able to pay for that. And there are certain cuts that have happened to rural hospitals. So budgetary adjustments they've had to make, right? Second of all, insurance payments actually matter to these hospitals. And so if these hospitals aren't getting the revenue that they used to, that causes a problem. So hiring a hospital, a full-time doctor, where they have like 6 patients, that's not fiscally responsible.
Right.
But let's be honest. You can't run a hospital if they have 10 patients in the hospital total.
Correct.
But that hospital is critically necessary for like a 200-mile radius.
Community, of course.
Right? So like you need that place there, but you can't pay the doctor. That is where the advent of the nurse practitioner has come. And that's where a lot of states have approved independent management. But even nurse practitioners, number one, they don't always want to work 24 hours a day.
Sure.
And B, there is certain experience limits that they have, that they don't feel comfortable managing certain issues. And that's totally understandable. Now, I work with a couple really outstanding nurse practitioners in like rural Iowa and rural Minnesota. Like, they're phenomenal. They really know what they're doing. But they also work Monday to Friday or Monday to Thursday and not 24 hours a day. So these companies come in and they say their business model is this. They take like, yeah, we're not going to charge you an arm and a leg in one hospital. And where they make their money is they get like groups of hospitals. And they say, we'll cover you for certain times. And they have their own pricing module. And it tends to be much more effective for the hospital. So now they get to see their patients. They get to treat their patients. Their hospital doesn't have to send those patients out, right? Because that's also revenue for them.
Sure.
And then the flip side is they don't pay a lot, right? And I actually think it's fractions from what I understand.
So it's almost like it sounds like a win-win for these hospitals.
Yeah.
Do these hospitals lease this technology, or do they reach out to companies that provide this service? Like, how would they get connected with you, for example?
Right. So the company I work with is called Avel, and they were like, I used to work for a different company, and then that got bought by Avel. And there are a number of different companies out there that do this, but yeah, like the technology comes with like the company. And so they have like technology with the computer system, the video system, and then we get access to their electronic records. So what's really great is that the telehealth doctor isn't making up notes and orders in some random system. It's actually putting it in the same record system that the hospital is using, which is the reason why we had to get credentialed in every one of those hospitals. Which is, that's a barrier of part of the care, but that's part of the benefits of this.
Yeah, I have limited experience in telemedicine, is why I've been asking so many questions.
Yeah.
This is very, very interesting. I remember in residency, there was a service when we worked in the cardiac ICU or medical ICU that was called Doc in a Box. So if I was a resident on call, if there was truly something going on or a problem, again, providing that reassurance, you could hit the doc in the box and he would be there to guide you in the decision making, which was fantastic. So
Really interesting.
Yeah, doc in a box.
Yeah.
Most of my experience now with telemedicine really stemmed from the COVID pandemic. So when patients were too scared to come in and see me, this was a viable alternative for them. So at least in the outpatient world, I use it frequently. I think doctors have to be very careful on how they use it. If a patient is outside of their home state and they're not licensed in that state, you cannot do or provide telemedicine services. So there is a certain protocol that when my staff calls a patient for an appointment, there's very specific questions that we have to ask and also document. So who's on the phone call or who's on the video with you? Where are you located? I know I have a lot of patients that travel to Hawaii or California, and I think they are smart enough now that they will probably tell us maybe what we want to hear, but I am licensed in 5 states and I make it very, very known that I can only provide those services. If they happen to say that they are in Canada, I have to end the service. So
that's the key, that you need to be licensed in the states that they're working in. So they're going to. The other thing that's really important is you need to be licensed in the state you're residing in.
Correct. And
So
you document that.
Right. So like, you can't be living in Puerto Rico and then like, and there's a reason why I say Puerto Rico, because they don't have federal tax.
Yeah.
Right. And then do telehealth for like Maine and Minnesota.
Sure.
Right. And just live off the grid like that. Like that doesn't work that way.
Yeah.
So when I did telehealth, when I started the telehealth thing, I had the Minnesota, North Dakota, and Iowa license right away, but then I had to get a Florida license. And the Florida license takes like a long time. Yeah. So that one took a long time. So the thing that has helped now is that there's this thing called, what is it called?
IP.
IPSS,
where it's almost a central
application.
application agency.
There's a different name for it. I'm going to kick myself
it's
when I
okay.
remember it. But yeah, there's a central process where the home state licenses your license, and then you can get issued in all sorts of states.
Quickly.
Yeah, there's
That's what
certain
I did for Florida.
there's certain states that don't do it. Like
Participate in it.
I think California doesn't, and I think a few. But now it used to be like half the states. So
Right.
now
Yeah.
I think 90% of the states.
Yeah.
can-
And I just went through this process recently with Florida, and I got my license pretty quickly. So
How quickly? Just wondering.
I think a month. Oh, honestly, everything. Obviously, I have a Nevada. Nevada's my home state, but they took all of that. The only thing I really had to do that took the longest time was having someone come to kind of sign off on and make it all legal. So
Oh wow.
I have it
Yeah.
notarized.
Yeah, the notary.
Yeah, just my signature and my identification and my driver's license.
Yeah.
But they contacted Nevada, and Nevada sent them all of my information, and I was licensed.
That's
So
awesome.
it was nice.
Yeah.
The other thing it's important to document, especially for those physicians listening, it's important to document the time that you are involved in the telemedicine. So when I and this goes for all of documentation with patients' notes now, I document the time that I was reviewing charts,
Okay.
speaking to specialists, reviewing hospital notes. I document the time that I'm actually with the patient. And I will even document the time if I'm doing a prior authorization for an MRI. If that takes 30 minutes, I'm going to document that, and then that total time. So believe it or not, that does validate whether I bill for a 99214 or a 99215. But here's the interesting thing. When I bill, you have to attach a 59 modifier onto the E&M code, but I get paid more doing telemedicine than I do if I were to see a patient in clinic
Really?
face to face.
Really?
Why?
That's probably because they don't know. Dang it, you shouldn't have told anyone.
Can you delete that?
Yeah. But
But
so
my
now,
reimbursement is more.
oh, interesting.
Mm-hmm.
Well, that's interesting. Yeah, it's a matter of time until they remove that from there. So
Yeah.
So in the outpatient world,
Yeah.
are you using telehealth frequently?
Frequently. Yeah. Obviously, when patients are in the practice, we let them know that this is a service that we offer.
Mm-hmm.
I do prefer to see patients face to face, but let's say you have a patient that came in for blood work and most of their blood work is normal. I don't really want them to come in and waste the time and drive in. So I will have my administrative assistant get them on the schedule for a telemedicine visit. Takes me 5-10 minutes to review their labs. They're happy they didn't have to come in. So it's also allowing me to see more patients, and it makes better use of my time at the end of the day. So part of the concierge service is we do offer telemedicine.
So I find that balance really challenging. I shouldn't say challenging, really beneficial. That I should always see my patients in the clinic.
Absolutely.
But the convenience factor from the patient side is, hey, you're at home, you're at work. Let me just sign on. I got you. Like I had a patient that needed to see me. I was at the airport.
Yeah.
So I went to the Delta Lounge, and then they have these in Minneapolis, they have these little units. And so I went in there, closed it, and then I got on Zoom and it's silent and it's quiet.
Sure.
And actually it's completely sealed. So they couldn't see anything. And I was like, well, this works out really well. And I told him I was at the airport, and the appreciation he had for it.
Sure.
Because he was worried about going to the urgent care or going to the ER, and we were able to manage it right then.
I think it validates you as that provider too. I mean, there's been many times that I've been in an airport and a patient needed me, and I took 5 minutes to address their concerns. So that's having ownership, right, of your patient.
That's also the night. I know, people always talk about that with the concierge, and they're like, "Don't you hate the fact that you're 24 hours on call?" I'm like, "No, this is kind of why I wanted it.
Yeah.
It's not a lot of patients.
No.
You take ownership of those patients.
They're your patients.
Yeah.
And I think ultimately you set the standard and the expectation. I'm there if you need me. Now at the beginning, patients were calling me at 3 a.m. for medication refills. I had to retrain them that is not necessarily an urgent matter, right? So, and you know what? At the end of the day, they're paying for a service. So, like my dad says, they're paying you.
Yeah.
I would probably call you at 3 a.m. for an ibuprofen I order as well. So, please don't. But
X-nay on the 3 a.m.
yeah. But no, I really like telemedicine. Even the fact, like, if a patient has a rash, they can easily take a picture, upload it into the system, and we can actually see it, measure it, and basically inform the patient if they need to come in or not. So I think it's really, really a nice service for patients.
Yeah. So I think the future of telehealth is very positive and very strong. I wonder how AI is going to play in that, because, I'm going to be honest with you, I don't trust anything that's coming out on like social media.
Right.
I read somewhere that like 50% of stuff that's on, again, this fact could be fake too, but 50% of the information that AI is like reading from has been AI regenerated.
Sure.
So like sometimes you worry, like, what happens in the telehealth space, because it is a screen.
Sure.
Does AI get involved in this? Could that be for its benefit? What if, just like, imagine I turn on the screen and the screen has great view, all of a sudden AI identifies that rash as the problem, all these like things that are popping up.
Or that AI is challenging your diagnosis.
Well, I'm more optimistic on that. Like, I think AI is going to be there for diagnostic improvement. I don't believe that it's going to be there to like,
I hope
Stanley Kubrick 2001 sort of fight against you picture. I do think it's going to be supplemental to help. So I imagine that one day there'll be a screen that pops up. I'm looking at you, you're complaining of abdominal pain, vital signs pop up on the screen, and everything is like helping me with a diagnosis. We got orders putting in, like, that would be an ideal situation.
And I think that's where remote patient monitoring is so key. And again, something we did offer at Parker Medical, but how often you see patients using their watch to keep track of their health information, but who's really monitoring that, right? And this is where I say all along that this is where concierge medicine plays an important role, because if we could access that information remotely, we could intervene a lot sooner and basically say, hey, did you realize that you had 3 episodes of AFib? Granted, I don't think on one rhythm strip we're really able to specifically capture AFib, other than, maybe it's just a PVC or another arrhythmia, but I think in the future it'd be really nice to have that capability. So
yeah, that would be amazing.
Final thoughts.
Regarding telehealth, I think the future is extremely bright. I think the future for telehealth and rural America is extremely bright. And I truly feel that it's going to be revolutionary to small town hospitals as they adopt it. It'll keep the communities strong. It'll keep the communities growing. And then eventually it's possible that telemedicine will be not the use of only medicine, but it might actually be in addition with other providers in that facility.
So if a hospital administrator is listening to this, how would they contact you?
There's a link in the bio.
Okay, all right. I'm trying to help you out here.
I don't own any ownership or say so just, call our clinic.
No, well, thank you. I did not realize all the details with that, so it's fascinating. So
that's really cool.
Yeah, stay tuned.
Telemedicine has opened the door for care in places that used to have none. And for a lot of small towns, it's not just helpful, it's the only way their hospitals stay alive.
And as tech gets better and as more hospitals adopt it, this is going to be one of the biggest shifts in how Americans receive care. It's not replacing doctors, it's actually giving doctors the ability to show up where they've never been able to before.
If today's episode gave you a better look inside the world of telehealth, hit subscribe, leave us a review, and share with someone who works in healthcare. And as always, shout it out from the rooftops. And if you're in Tampa or Las Vegas and want a doctor who actually knows you, who's accessible, who practices evidence-based medicine, not shortcuts, we'd love to take care of you. In Tampa, visit Seth Premier Medical. And if you're in Vegas, we want you to see the team at Parker Medical. All the links are in the show notes below.
Thanks for listening, and we'll see you on another episode of Out of Network.